Hello, my name is Logan Rebay, and I'm with the Palo Alto Dental Hygiene Program. Today, we'll be discussing the periodontal probe. The periodontal probe is a hand assessment instrument with the primary function of determining the sulcus steps of patients to help make a clinical judgment about their periodontal health. Today, we'll be discussing its design characteristics, the functions of the instrument, as well as the instrument technique, and finally, the clinical application.
First, we'll be talking about some of the design characteristics of the probe and what sets it apart from other instruments. The handle is this portion of the instrument here. Often, it is a thick handle to accommodate ergonomic grasp, and you can see here that is a single-ended instrument with a blunt tip that can be used for mobility tests. At the other end of the instrument, indicated in this region here, is what is called the shank. It is relatively thin and is common to other assessment instruments that allows tactile sensation, but also indicates that there is no need for excessive pressure. Actually, in the case of the periodontal probe, there will be zero lateral pressure. And here, if we zoom in on this portion of the instrument, we will get a better image of the working ends. Compared to most instruments, the probe has a very long working end, and this is because it acts as a ruler with calibrated markings and indentations that measure out the depth of the sulcus once it is inserted. It has a circular cross-section and a blunted tip. Each marking represents 1 millimeter. And you can see that at a certain point, there will be a thick band. This thick band is an indication for measurements and for faster readings. The bottom portion of the thick band is the next sequential millimeter. The top portion is again the next sequential millimeter. One thing of note is that the first 3 millimeters are below this first thick band. This is what is considered for healthy sulcus of 3 millimeters or less. Anything above 4 millimeters would indicate disease. The shank can be further subdivided into the terminal shank. The terminal shank would be this area of the probe here. You can tell that the terminal shank is marked from the first bend until the bend of the working ends. The bend of the terminal shank and the working end meet at a 90 degrees angle. The primary function of the periodontal probe is to determine the sulcus depth. A sulcus depth of 3 millimeters or below is considered health. A pocket depth of 4 millimeters or above is considered a periodontal pocket and an indication of disease, possibly periodontitis. Some considerations for clinical attachment level are gingival recession and gingival hypoplasia. In the case of recession, you would add the recession from the CEJ to the gingival margin to the overall pocket depth. In the case of gingival hypoplasia, you would do the opposite and subtract the overgrowth above the CEJ from the overall pocket depth. The probe is held with a modified pen grasp. The thumb and index finger hold the handle with minimal pinch force and no blanching of the fingers. The middle finger rests across the shank and applies no lateral pressure. The ring finger is used as a fulcrum and rests on the occlusal surface of a secure tooth. The working end is angled so that it is parallel to the long axis of the tooth. The placement is within the sulcus and is inserted subgingivally until it reaches the junctional epithelium. Light pressure of 10 to 20 milligrams is applied with zero lateral pressure. There should be no blanching of the fingers. The instrument is rolled to maintain the adaptation and is angled into the coal area for an accurate reading. The stroke uses digital activation and is using a walking or bobbing motion and remains within the sulcus until needing repositioning. The tooth is divided into 6 zones that all produce independent readings. These zones are the facial mesial, facial distal, lingual, and lingual mesial. Generally, the order of probing follows the software being used and is typically tooth number 1 to 16 facial, 16 to 1 lingual, and then 32 to 17 facial, then 17 to 32 lingual. The deepest reading in each of the zone is the final reading that is used and counted on the software. Lingual surfaces require indirect vision and indirect illumination with the mirror. Lingual surfaces are otherwise probed in the same manner as the facial surfaces. Lingual surfaces commonly have a shallower sulcus depth compared to their facial counterparts. Notably, other secondary functions for the probe exist, such as occlusal measurements, such as midline deviation or overjet, in which 2 to 4 millimeters is considered normal, 4 to 6 is considered moderate, and anything above 6 millimeters is considered excessive. Exploring for bleeding is also done, in which up to 30% is allowed before it is considered a generalized state of disease. Besides the teeth, lesion descriptions can also be done with the probe. Yeah, I think that's fine.